it's an interesting thing, this topic, because I am asked, I go around, I give a lot of talks, and I'm asked to give this talk more than I'm asked to give any other talk, especially in the medical community. There's just a lot of questions and curiosity and unanswered questions. And I want to recognize that this slide set has been worked on for many years between myself and Dr. Brant Hager at UNM. And so he deserves credit for the content as well. But so let's just jump into it. We'll talk a little bit about, cannabinoids and kind of how they work in the brain a little bit, and then look at really what do we know about the risks and benefits and uses, and what does the medical literature actually tell us. But one place I want to start is kind of what I was talking about before. Again, in my experience, it seems like everybody is in one camp or the other. Most people are either for or against cannabis as medicine, and it makes dialogue a little bit difficult. And we even see this in the medical literature. So, for like medical articles and stuff, for anybody who's not familiar, we use this process called peer review, where if I do a study and I write a paper about it, before that paper is published, it's sent out to a bunch of other people who have some scientific background or experience, and they look at it and they read the paper and they come to their own conclusion. Am I making stuff up or not? Like, does it make scientific sense or not? And in most cases, they send it back with lots of comments and they say, you got to change this. You sound really biased here. And you have to work on it a little bit. And this is like our system. It's this really cool democratic system of reporting on the scientific method. And it works really well, except with cannabis literature. And I would suggest it has totally failed with cannabis literature. I spend more time looking through cannabis medical articles than any other single topic of medical articles, because I have to just sift through all the junk that's out there. And so here are two examples. These are titles of two papers. One that came out 2 years ago now. It was this really big thing, therapeutic effects. It was from the National Academies of Sciences, Engineering, and Medicine. Really big. The therapeutic effects of cannabis and cannabinoids. Those are just the chemicals in cannabis. An update from the National Academies. Right? A big name kind of organization. But notice, this is an article that's just about the therapeutic effects. Here's all the good stuff. Let's not deal with the bad stuff. Right? And maybe that's okay. Except that, for example, when they looked at or when they address PTSD, they ignore the biggest study to date that had already been published in this part of this article, and then they go on and they say more science is being done, and it's probably going to come out pretty good, which is not how the scientific method works. You don't say I'm going to do this experiment; it's probably going to work. In fact, I'm just going to publish it. It's probably going to work. That's just not science. Totally biased. And if you compare that to the bottom one, current evidence of cannabinoid-based analgesia obtained in preclinical and human experimental settings. It just looks at here's the current evidence. It's not saying where it works or where it hurts. It's saying here's the evidence. Analgesia is pain relief, and preclinical really in this case means in non-human animals. So here's the results from research looking at pain in non-human animals and animals. And it turns out it's a very balanced report. But you have to sift through a lot of junk to find the good articles. So I think it's failed. So a little bit about cannabis. Pretty interesting plant. The main chemical in cannabis that people use cannabis for is that one that the triangle is delta-9 tetrahydrocannabinol. So that's THC. And this is the chemical that gets people high. The one next to that, cannabidiol, that's CBD. And these are really the two cannabinoids that are in the highest concentrations in cannabis or marijuana plants. And they're the two cannabinoids that we know the most of or most about. There are pictures of two other cannabinoids here, but there are actually about 78 other cannabinoids in cannabis plants. So there are roughly about 80 cannabinoids that are in cannabis plants. most of them are in such small amounts that I'm not convinced that they really have any like action that we can separate. And we essentially know virtually nothing about them. We know the most about THC and the most about CBD. And what's interesting is CBD almost got bred out of cannabis plants, because so most people were growing their plants to get you like the biggest high, right? Make it the more kind of chronic. And there's just a ratio of THC to CBD. So essentially CBD was being bred out of cannabis plants. And then all of a sudden there was this appreciation for, wow, this actually is a pretty neat chemical that seems to have some medicinal value and some neat properties. And luckily that was done in time to breed CBD back in. So we were kind of afraid that we actually might lose it. These pictures don't explain a lot. I'll say this. We have two main cannabinoid receptors in our brain. We just call them CB1 for cannabinoid 1 and CB2. And this is where the cannabinoids like THC or CBD have their action. And THC binds especially to these CB1 receptors, and that's how they cause the release of neurotransmitters that have their effect in the brain. And it turns out CB1 receptors are all over the brain. So in this case, like purple and dark blue is where you have not a lot of these receptors. And then as you go into like turquoise and green and yellow and orange and red, that means more and more of these receptors. And they're all over the place. And they're like in the areas of memory, right? Which is why we see memory changes with cannabis use. They're in areas of our mood regulation, which is why we can see mood effects. They're in the front part of our brain where we think critically, and we make like kind of complex human-like decisions. They're in the back part of our brain and in the balance area of our brain, our cerebellum, which is why reaction time is affected, and really, which is kind of plays a big role in what's trying to be identified and still defined, right? Which is how do you do, like what's the key to field sobriety testing? Because nobody's cracked that code yet. And so why do we have cannabinoid receptors anyway? It's because God intended us to smoke marijuana. And that's the end of the lecture. No, but that's certainly some people's reasoning. No, so cannabis has an effect because we have these receptors, and it turns out we have receptors because our brain makes its own forms of cannabinoids. We call these endocannabinoids. And there are many more than just two, but there are two listed here, 2-AG and anandamide. And they're pretty interesting. We know the most about these two. Anandamide, for example, is a cannabinoid, and as far as we can tell, its main action in the brain is to help our brain forget things, which may sound weird. Like, why would we want to forget things? And so here's my analogy. Imagine that you had a piece of paper that you wanted to find. And we came into this room, and this room was filled with filing cabinets. And they're all filled with paper, right? But we're looking for one piece of paper. It would be pretty hard and inefficient to go through all those filing cabinets and all those pieces of paper to find just one, right? But if instead we had a system that kind of got rid of certain filing cabinets and certain folders, it would be easier to find the one paper we're looking for. Our memory is like that too. It turns out some people have the ability to remember literally everything, and it is not a good thing to have. They actually like have difficulty figuring out which like type of cereal to buy at the store or which clothes to put on, because there's so much information in their head that they can't sift through it in an efficient way. So it sounds good. Having like a really good memory is awesome. Remembering everything can be in a way crippling. And so anandamide is one of these chemicals that actually helps us forget things. Unfortunately, we don't really get to choose what we forget, but the brain takes care of that through a couple other things, through associations and the emotional significance of things. But this also explains why memory problems are so frequently seen in people who use cannabis.
And males.
And not find out. Now there are these CB2 receptors too, and these are distributed throughout the rest of our body. And The CB2 receptors, cannabidiol or CBD definitely binds to these. And again, so I said there's bias about this, et cetera. I certainly have my own bias. I think if there's clearly a medicine in cannabis, CBD is it. It is possible THC maybe is a medicine. I'm not sure. But CBD it affects our lymphatic system, so like our immune system. It's been clearly shown to help with a very specific type of infantile seizures. There is some early evidence of its help with pain, and CBD does not get you high at all. So CBD does not bind in those brain receptors. It's not intoxicating. It also does not trigger the drug screen. So in urine drug screens, we test for THC, and CBD does not bind to that. So if I take CBD every day and I pee in a cup, the THC result will come out negative, as long as I'm also not using THC.
I have a Detective Bailey's VIU.
Yeah.
So people that have told me that they take it for pain, and some people have even said they put, like, because you see it like in oil that they can rub on their skin, but drops in their mouth. So that is not getting them high. That is not.
So it's a good question. So the question is kind of if they're taking CBD only, then it's not getting them high, right? And so if they're smoking something for the CBD, they're getting high.
Oh, okay.
Yeah, because you gotta extract just the CBD. So CBD can come in tinctures. That's like the kind of liquid under the tongue. Comes in salves. Comes in patches. Comes in pills. Also, totally legal. It's not a Schedule I drug. You don't have to have a card to get it. It's sold at pharmacies. There are CBD stores around town. Most of the CBD is derived from hemp, and there are federal guidelines about, as long as it has this like microscopic amount, no more than this microscopic amount of THC, then it's good. Not enough to get people high. All right. So, and then there are some other things too, and this is a little bit technical, but so delta-9 THC or just THC, it's a CB1, we call it a partial agonist, just meaning that it activates the CB1 receptor, and that's what gets people high. But there's kind of a ceiling effect on it. Cannabidiol is what we call an inverse agonist. And that gets to the comment that was made about, it seems that some people with psychotic illness who take CBD might benefit from it. So CBD can kind of have, it seems like an opposite effect to THC. The story's a little thicker than that. And then there are these synthetic cannabinoids. So it's kind of an interesting story. So the synthetic cannabinoids are things like spice and K2. And so back, especially like in the 80s, people were wondering, hey, scientists were wondering, why does pot get people high? Like, how does that happen? What's the science of it? And so at these universities, they started to study this. And when we study things in the brain, we oftentimes make a little chemical that will bind in the receptor that we can also tag with something that is radioactive oftentimes, so that then we can like do a scan and it will light up. We can tell where it's going. So they made these, we call these ligands. They made these ligands that acted like THC. And it took huge university labs to make them at the time, lots of money. And then all of them were named for where they were made. So now we go ahead like 30 years and it's really easy to get the components and the ingredients for this stuff. And you don't have to have a whole lab in a university. You can kind of build your own lab. And because this was science, they published at the time, like how to make these, right? That's science. And so now people with clandestine labs make this stuff, and those are synthetic cannabinoids. That's spice. We call them spice because that's how they were originally sold, or K2. And they have more technical names, right? Like the first one, or one of the first ones that got really big and well known was called HU210. It's probably the most famous synthetic cannabinoid. That stands for Hebrew University, and it was number 210 of all the ligands that they were making. They tell where they come from. It's kind of interesting. Now, those are full agonists. So they're not THC. Spice and things are way more potent, and sometimes as much as like 300 times as potent as THC, which is why people have very different experiences when they use spice, right? And oftentimes people who are using spice, especially these days where they're hard to get because they've mostly been made illegal, are people who interact with like if I'm on probation or if I'm on parole and I want my urine drug screen to come out negative, I can use spice. It's not THC, so it doesn't show up on my drug screen, but I get high. But plenty of people actually end up in those circumstances using spice, and they're like, this is not what I was looking for, because they get way higher than they expected to, and are far more likely to become psychotic. So let's talk about all the good, the bad, and the ugly when it comes to cannabis, because it's really the only way to kind of talk about drugs. We gotta have a balanced discussion. So first of all, the good, right? Why do people use pot? Because it gets you high, right? It can cause euphoria. For some people, it can cause calmness, not for everybody. For some people, it can increase their appetite, and for some people, that's a problem, and for some people, that's quality of life, and it's really good. Some people will become more social, right? I go to a party, I get high, and maybe I don't feel as self-conscious, and I can talk to people, and that's really fun. Some people it has the opposite effect. This time perception alteration is very common, and is actually one of the reasons why our federal government has for a long time classified cannabis as a hallucinogen. And I tend to think of it that way. It's a technical term. Classic hallucinogen are the other hallucinogens like acid and mushrooms and stuff. They work in a totally different way. They work through this chemical called serotonin. So it's not a technical thing, but I think it's good to think of it that way. And then color perception, can be it can be really groovy, right? Now, what about the bad? So cognitive impairment, right? People can think slower. They can be less attentive, have poorer focus. They can also make bad judgments in terms of like maybe decisions that they wouldn't make if they weren't high. There is motor coordination impairment, which is where field sobriety testing comes into play. And this is very well documented. It comes in two forms. One is in slower and less accurate motor actions. And then the other thing that can happen is more impulsive actions, actually. So where people are moving kind of before they're thinking, and so again, might misjudge what they're trying to do. But it's not just one or the other. Some people will have a panic attack. Some people, their anxiety gets worse when they smoke pot. This is usually kind of rate limiting. Typically, if somebody smokes pot and they have a panic attack, they're unlikely to smoke pot again. I don't like that. I'll go for whiskey or whatever. Some people will experience paranoia. And the paranoia isn't always delusional, right? It's not always this totally extreme form, but it could be kind of a suspiciousness or like what's going on, or hey, is that a cop, right? Or hey, is he looking at me? Or it could go as far as a delusion where it's like fixed and firm, right? Where people have this, I know that they are trying to hurt me, or I know that they have a problem with me. And it turns out that the more frequently you use cannabis, the more likely anybody is to develop paranoia associated with it. So for example, people who use it less than weekly, compared to people who use it weekly, people who use it weekly are more likely. And then definitely the people who use it daily, way more likely than either other group to experience paranoia. You can also have hallucinations. And these can be visual or auditory. Now, most people don't experience hallucinations, right? Most people don't experience really bad outcomes, the really ugly that we'll get to. But some people do. And then, of course, conjunctival injection, that's just red eyes, dry mouth, tachycardia. These are things that are unpleasant and can be part of the bad. But what about the ugly? So some people will get more irritable or angry or aggressive on pot. Not common, right? Most people chill out. But it certainly can happen. There are plenty of people who will experience nervousness or anxiety. And it can be at different times. Maybe when they first smoke it, they're calm. And then maybe like 20 minutes, an hour later, they're more anxious or more nervous. And I think that difference can be tough in terms of helping somebody understand, because our brain is kind of programmed to remember the first part of the high. That's the part that forms our memory and our association, and not the latter part, right? And we see this with all drugs. So people who have been tweaking on meth for like 3 days and are psychotic and like angry and irritable, that's not what they remember. They remember the first 10 minutes after they smoked or shot up meth, which was like the best experience that they've had in a long time. And this is why our brains are vulnerable to developing addictions, because because they selectively remember the first good part. Some people will not sleep. Some people will have insomnia or disturbed dreams. Now, other people feel like they sleep better. So there is a split there. Some people won't be as likely to eat. Again, typically like with anxiety and stuff. Some people will be restless. They'll actually experience akathisia, like the symptom that people are going to experience when they take Haldol or other antipsychotics, where they feel this inner need to move. That can keep them up and cause insomnia, cause anxiety. Some people get depressed, right? And then some people can have these other kind of symptoms: sweating, headache, abdominal pain, or nausea and vomiting that won't stop. Now, another form of the ugly is addiction, and it's a well kind of often found myth that you can't get addicted to marijuana, right? But we've had a cannabis use disorder or cannabis dependence before that. We've had this diagnosis for a long time. Clearly, you can. Most people who smoke pot don't develop an addiction. Most people who use drugs in general don't develop an addiction, but close to 1 in 10, right? It's 9%, but I go easy with numbers. About 10% of people who smoke pot will develop a problem with it. And that number almost doubles if they start using in their teens. So we know that drug use during adolescence increases your chances of having an addiction or a substance use disorder later on, which is why right now the recommendation is not to tell kids, like, just don't use drugs. You can tell them that, that's fine. But understand that doesn't work. What we do is we encourage them, if you are going to use drugs, wait till you're 19 to start experimenting. And that's just statistics. If you start using before 19, you're more likely to develop a substance use disorder compared to if you start after 19. Just statistics.
Unless you get a house.
And they're out of the house, right? And then the numbers soar for people who use cannabis every day, right? And again, this shouldn't be surprising. This is true of all drugs of abuse. The more likely you use them, the more likely they are to be a problem. Yeah.
Rob Garnier, CIU, are just like with alcohol, are there tolerance issues or?
There are actually. It's a great question. So people actually develop tolerance fairly quickly to THC. And I sometimes use this as like a motivator. So we talked about a couple of different forms. There are salves, there are topicals, things like that, right? There are different ways to use pot. So you can smoke it, obviously, right? That's been done for thousands of years. You can cook it into things with oils like butter or oil, right? And that kind of gets the THC out, and then eat it. And so there's a whole edible thing that's its own issue for states that decriminalize, is how to regulate, how to label the edibles so that kids don't eat them, and how to do dosing. And then there are also two other ways, right? One is called vaporizing, right? So vaporizing is really where essentially you heat up either the cannabis plant material or cannabis oil to the boiling point of THC. So that the THC just turns into vapor, it boils, but doesn't burn, and then you inhale it. Because it turns out when you burn the cannabis, like the marijuana plant, you also burn some of the THC. And then you're wasting your money, man. And there's another form of that called dabbing, right? So dabs or shatter or wax. And this is where, so the original form of this was called butane hash oil. This is like the rest of the world uses normal hash, which is just resin collected from the plants. And then we really started in this country, butane hash oil. So you take, like, let's say a mason jar, and you fill it with your plant material, your buds, and you fill that then with liquid butane. And you put the lid on and you let it sit there for a couple of days. And what will happen is all the THC will seep out. The butane kind of causes it to come off of the leaf, and the butane will turn like a brown or green. And essentially you've taken all the THC off of the leaf. Then you put a hot plate on your stove and you pour your liquid butane, filter out the plant material, pour your liquid butane off of it, and heat it up like just hot enough to get the butane to evaporate and not so hot that you burn your face and it explodes. There are lots of YouTube videos of people burning themselves. Butane hash oil, BHO, that's also become, so and what happens is the butane comes off and what's left is just the THC. Then you take that off the heat, it dries, and it's kind of like either a waxy paste or sometimes like like toffee-ish. and you can shatter that, which is why it's called shatter, right? And then you use these attachments you can get like for a bong that has a hot plate where you heat up the hot plate and then you just touch the BHO or the wax to it and it'll like instantly vaporize and then you get that. The whole reason for this long explanation is that, so like in the most potent, like chronic of pot, we'll see it THC levels about as high. The highest that'll get is like 17, 18% THC. And wax is like 98, 99% THC. And so one of the ways that I try to motivate people to go away from wax is that it drives up their tolerance super fast. Like oftentimes when people are doing dabs or wax a lot, they say, oh, like plant just doesn't do me anymore, or leaf doesn't do me anymore. And that's because their tolerance has been driven up so high because they're smoking this 99% potent stuff. So the 18% potent stuff doesn't work anymore. But it's also associated with other problems. Yeah.
I had Officer Dixon with Mobile Crisis Team. A quick question. So earlier you had mentioned that if someone says, I'm smoking it for the CBD, they're actually doing it for the THC. Is it possible to have any kind of inhalation or smoking that is CBD? So
it's a great question. I have never seen a like CBD only or super high with virtually no THC plant. In New Mexico and in Colorado, at the dispensaries, there are rules that define that you have to do these assessments, these analyses, and I've never seen that. I've never read about it or heard about it.
But I guess what I mean is like, so with the CBD, they have products like you mentioned that are tinctures or whatnot.
Yeah.
Are there products where people inhale them?
So no, that aren't smoked. Like so actually yes. Like you can make THC oil, which is the butane hash oil, right, or ethanol hash oil cleaner, and those are like the little vape pens. So you can do that for CBD as well. So there are CBD vape pens.
Okay.
Absolutely, that you can vaporize, but it's not plant material. So if it's plant material, if they're smoking a joint or smoking a bowl, then they're getting THC as well.
Okay.
Yeah. Great question. So just to kind of go over like this idea of addiction, I'll just put up the criteria here. You know, these are criteria we've talked about in this network before. It's the same diagnostic criteria for all the substance use disorders, right? So the question is like, what does a cannabis use disorder or cannabis addiction look like? It's really where, you know, somebody's relationship to cannabis is getting in the way of functioning, right? They can't control how much they're using. It's causing problems with other relationships. Like we see this a lot with teens, right? As a teen, like, hey, is smoking pot causing problems with any relationships? No way, man. All my friends and I, we get together better. My next question is, anybody not like that you're smoking pot? Oh yeah, my parents hate it, right? My priest hates it. Like it's actually driving some conflict and other relationship problems. And that's meaningful in terms of the DSM.
My PO.
Or that it's getting in the way of obligations, right? So I can't get a job because I can't pee, right? I can't pee clean. Or I don't do sports anymore because I just don't really feel like it, right? I'm smoking bowls all day. Things like that. Is it getting in the way of your ability to be a student at home? Are you using it in situations where it's physically hazardous, right? So many people don't think that you can get arrested for DWI from cannabis. And again, a lot of places, especially Colorado, is totally working on how do we do good and meaningful field sobriety testing? I mean, do any of you feel confident that you have a good way to do
Nystagmus.
FST? What's that? Nystagmus? You're right. Maybe. But there are tons of other causes of nystagmus, right? And you can be really high and not have nystagmus.
Get the Doritos and throw them on the floor, and if they
See how fast they go? Yeah. So what has been found helpful, especially in Colorado, is divided attention tasks. That's like one of the most helpful things specific to cannabis. All right, so that's that. So what about other things, the really ugly? So some data, not great data, but at least some. So for example, looking at bipolar disorder, it looks like people who are smoking cannabis and have bipolar disorder, the bipolar disorder comes on earlier, younger age of onset, which there's some pretty good data that shows higher number of manic episodes in bipolar disorder for people who use pot. And manic episodes are really dangerous, right? Oftentimes, this is what leads people to get hospitalized. It leads people to get STDs or make really kind of dangerous decisions. We also see more depressive episodes. There is no good evidence that pot helps with depression. There are some people who say, hey, it's helped me with depression, right? But when we look at large numbers of people, so far there's no good evidence that shows a beneficial or therapeutic effect there. And definitely more psychotic features. We'll talk about that. There is some suggestion that there are more suicide attempts in people with bipolar disorder who use cannabis. And again, this should not be surprising because being intoxicated is the strongest risk factor for a suicide attempt. You know, when we're working in the ER and in our psych hospitals, like it's rare that people attempt suicide and they're not intoxicated. And this is just another intoxicant, right? It's most often alcohol because way more people use alcohol than any other drugs. But there are a lot of people on the other kind of with their own agenda who would like to say that it reduces suicide. No evidence to that. Now, schizophrenia, we have pretty good data about. Using cannabis, certainly we can say, seems to increase the risk of developing schizophrenia. Obviously, most people who use cannabis do not develop schizophrenia. And so the schizophrenia starts earlier, and it is a worse course. It is way harder to treat, which gets to the case that was presented, right? I have had patients who have schizophrenia, and we stabilize them pretty well on their meds, and their meds are working, and then they start smoking pot. And even if they keep taking their meds, they do not tend to do as well. Now, again, kind of interesting. So there have been some very small studies that looked at CBD, cannabidiol, given to people with schizophrenia and showed some symptom improvements, not huge, but some. Then there was this other drug that was being tested that was like a blocker, a CB1 blocker, a CB1 antagonist. And it actually showed really favorable effects on schizophrenia, and people died. They committed suicide. So which gets to this question of, is there a role of the cannabinoid system, our endocannabinoid system, in mood? That doesn't mean that pot is an antidepressant. But if we block the system, we just need to know more about what happens if we do that.
What percentage were committing suicide?
I don't remember the percentage.
Okay.
It was not a large number, but it was enough to kill the drug. And it's done.
Damn.
Yeah. But it helps with psychotic symptoms. So very interesting. Right. Not worth it. But, so what about depression? Again, increased risk of suicide attempts. We're going to talk about PTSD in a second. And then cannabis use disorder. Again, so like, I know prevalence and things seem a little weird. About 10%, right? 9% of people who use it kind of ever will develop a cannabis use disorder. And if you start using it in teens, that about doubles, but then really high rates if you use it every day. Okay, so let's talk about PTSD. Because PTSD, if you look at the New Mexico Medical Marijuana Program, PTSD is the #1 reason why people have the card. So it is the most common reason people have the card. And there are many other states who rejected PTSD on their systems. Now, I had the opportunity of talking to the people who wrote this law originally. And they were really clear that the law, the medical cannabis law, has nothing to do with science. And they even said that. In fact, what they say is, we can't wait for the science. They have constituents, right? They say our constituents, our voters, tell us this is helpful. We want to make it available to them. And so that was done. To date, this is the biggest study that was done, published in 2016, looking at cannabis use and PTSD. And it was done in the VA population. And it showed a couple things. The first thing is, if you look at that top box, it says average PTSD checklist score. So that's like the score of your symptoms and how severe they are in PTSD. And between these two groups, if everybody has PTSD, compare the people with PTSD who are using cannabis and the people with PTSD who are not using cannabis, there is exactly 0 difference in their scores. There is no reduction in PTSD severity on this checklist. Now the bottom box is just kind of interesting too. So they also looked at kind of people who are like cannabis users in general, and then people who are not cannabis users, and people who are using other drugs other than cannabis and have PTSD, and essentially looking at like how much alcohol do they use. The people who had PTSD and used cannabis, they did drink a little bit more alcohol than the people with PTSD who did not use cannabis. And this is significant because there's just a lot of, there are higher rates of intoxication period in PTSD, right? And again, PTSD plus alcohol use does increase significantly the risk of suicide for everybody, right? This is also some of the findings from law enforcement suicide data that we've looked at in this clinic, this project. One other thing that I don't have up here is that one of the big differences between the two groups is that the people with PTSD who use cannabis compared to, in this case, compared to people who did not have PTSD and used cannabis, what they compared was their cannabis withdrawal symptoms, right? So when you stop using cannabis, you have cannabis withdrawal. Again, it's a diagnosis we've known about for a long time. It's in the DSM. It's well understood. And people who have PTSD experienced more severe cannabis withdrawal symptoms than the people who did not have PTSD and went through cannabis withdrawal. And this kind of makes sense because, so the most common symptoms of cannabis withdrawal are getting more irritable and having difficulty sleeping. And these are things that happen in PTSD anyway, right? When your nervous system is kind of stuck in survival mode. But so it's worse in people who have the PTSD and then stop using the cannabis. Just kind of interesting. I'm going to skip this because, well, except for the last bullet, which is to make some of the other bullets, they're controversial for silly reasons. But the question of mortality, so that's the other myth that's out there. Nobody's ever died from smoking pot, man. So people don't smoke pot and then stop breathing and die, like with heroin. That's true. It actually turns out hundreds upon hundreds of people die from pot use every year. Canada is one of the best in reporting this. Canada, and I need to update my slide because the data is old here. They have an annual cannabis mortality report, and it documents all these things. It's not talked about a lot here, and what happens is, I mean, we have a bias in this country anyway of not blaming the right thing. Like so many people even die from tobacco, and what their cause of death is cancer or stroke. Turns out the tobacco caused those, right? And some of these are injuries. Some of these are motor vehicle crashes, for example. I mean, you could say, well, the car killed them. But like it's because they were intoxicated. So actually hundreds and hundreds of documented deaths every year. Far less than most other drugs. So that's some of the risks, some of the problems, but I think it's important to talk about the good too. Is this medicine? Some people will say, we really haven't done any science, and it's not really accurate. We need to do more science. But for example, studies looking at people who have nausea and vomiting who are getting chemotherapy. There's rich, tons of science done here. And what's cool is and important is that they've done science with different forms. There are medicine forms, like a pill form of THC called Marinol or Dronabinol, right? It's different because you have to eat the pill, you swallow it takes like 40 minutes to absorb through your intestines. Not the same as smoking it. So it's been studied with smoking with this mouth spray called nabiximols, which is a 1-to-1 THC to CBD, and with Dronabinol, that's the medicine, and clearly works. Like clearly people report improvements in nausea and vomiting after they have chemotherapy. I would say medicine. Cannabis is a medicine for nausea and vomiting after chemotherapy. The other one is appetite stimulation in HIV and AIDS. So very commonly with HIV and AIDS is that you lose your desire to eat and then you waste away. You lose your muscle mass, and after you've lost enough muscle mass, you start to lose like brain and stuff like that. And cannabis, both smoked and the pharmaceutical stuff, helped to stimulate appetite. And if you can imagine, if you have HIV or AIDS and you're super sick and you can't enjoy food, but now you can enjoy food, I say that's quality of life. In my book, medicine. Medicine. Turns out, by the way, they did not actually gain much weight, but they have the increased pleasurable experience of enjoying food again and being hungry, which I think is quality of life. Now, pain is a little harder. There are a lot of studies, way more than 28 studies that have been done, but these are the 28 best studies. The problem with pain is that there are all kinds of different types of pain, right? You can have nerve pain. You can have the fibromyalgia, who knows what that is, probably mostly musculoskeletal pain. You can have cancer pain. You can have arthritis, right? So it's a kind of a mixed bag of things. All of these things have been studied and with various forms. And if we look at them all together, it does not do a great job of reducing pain, which is the second highest reason that people are on the card in New Mexico, are pain states. We generally see, if we look at all the studies, about a 0.3 change on the 0 to 10 scale. So like your 0 to 10 of, what you're paying, it's an 8 out of 10 or whatever. So that means that cannabis on average is reducing the pain from like an 8 out of 10 to a 7.7 out of 10.
Now, is that just the cannabis, the oil, or?
It's all these things. So it's been looked at it with all these different things.
Okay.
Yeah. And no good human studies with just CBD. Those are being done now. And we'll see how those come out. So they don't do a lot of change in terms of the actual pain intensity. However, in a number of studies, what people rate is they say, but my quality of life is better. When my quality of life with pain and when I smoke pot. So maybe it's not reducing the pain, but is it affecting quality of life? People can report that it is.
Okay.
So again, is it medicine? Is it not? It clearly feels like medicine to some people. How are we doing on time?
Yeah.
Okay. Just to talk a little bit and just briefly about the medical program that we have here. So we're one of the states where we have a list of qualifying conditions. Most of these conditions have no science behind them. Right?
Mexico.
And some of them are kind of a little bit like misleading. Like, so if you have cancer, again, there's like, it's a medicine for some cancer related side effects, right? It does not cure cancer. It is not an anti-cancer drug. Multiple sclerosis, there's actually pretty good evidence, especially for this 1-to-1 CBD to THC form that is not approved in the United States, but is approved in most of the rest of the world. Huntington's disease, 0 data. Parkinson's disease, 0 data. If you're in hospice, I think you should have whatever you want. Glaucoma, like for a long time was like, hey man, it helps my glaucoma. Pot does not do as well as the medicines for glaucoma. It does not outcompete them, and it does not do even as well as them. HCV and in treatment, that's hepatitis C. There have been some kind of early analyses that actually suggest that if you have hepatitis C and you smoke pot, you're more likely to develop cirrhosis. So again, like it gets on the list not because of science. Is this the one? So I need to go back and update these again. The numbers. So at least 2 years ago, and I'm sorry it's so out of date, there were about almost 47,000 people on the program. But just notice, 2 years before it was 14,000. I mean, the numbers have just skyrocketed. And again, at that time, PTSD was the number one reason. The various kind of chronic pain diagnoses was number 2. And then everything else was kind of a small smattering of stuff. But I say, all this is, people are biased and there's lots of silliness out there. I would encourage you, even don't just take my word for it. Right? Go out there and read about it. Try to sift through things. I think what's important to me is just that we have like a balanced conversation.